I'm Zubin Shroff from the Alliance from Tech Health Policy and Systems Research, and with me moderating this session is my colleague Gitanjali Lamba. And welcome to this webinar that examines country experiences of how COVID-19 has impacted vulnerable urban populations. Some of the examples will look at rural populations as well, though the theme is largely around urban populations. And we can see that how COVID-19 affects vulnerable people in very different ways, in fact, from other groups and the additional challenges they face. So difficulties not only in access to health services that they face that are increased due to services being disrupted, challenges in maintaining precautions due to living conditions, as well as the economic effects of both the disease as well as measures to address it that then influence how vulnerable populations are able to cope. And addressing this COVID-19 in these settings requires very different solutions to populations that already have additional challenges. And to this end, we will examine in this webinar experiences from 6 settings: India, Kenya, Sierra Leone, Guinea-Bissau, Ghana, and Vietnam, very diverse settings, countries of very different sizes and all over the world. And we want to learn from the experiences of 6 different organizations and groups that have been engaging with and researching this particular thematic area. And with this, I'll hand over to my colleague Tanji Lamba to discuss some of the tech and housekeeping issues.
Good morning and welcome everyone. Thank you, Zubin, for your introduction. So I just wanted to run through a few things about the Zoom webinar platform that we're using. You'll notice that you'll automatically all be on mute with your cameras off. If you have any issues with technology, please feel free to type them in the chat box. You can also ask questions of our panelists via the chat box or via the Q&A function as we go. There will also be the opportunity to ask questions live at the end. The structure of the webinar will be 6 speakers, as Zubin has mentioned, from the 6 countries above. They will talk for 10 minutes each, and we will have 20 minutes for questions at the end. And as Zubin mentioned, the Alliance is convening this webinar to facilitate sharing of lessons from these 6 settings. However, our panelists today are not associated with the Alliance, and the views that will be expressed here today should not be taken as recommendations or guidance from the Alliance or from WHO. Rather, we are convening this webinar to share learning, and we hope that you enjoy. So the first presentation that we will have will be by Preetha and Niloufar, who will be talking about community engagement models to tackle COVID-19 in urban slums. They're both based with the Bridgespan group in Mumbai. Welcome, Preetha and Niloufar.
Thank you, Gitanjali. I'll just wait for a couple of seconds while the presentation comes up. Great. So thanks everyone for making time. It's a pleasure, although in very trying circumstances where the whole world is reeling from a pandemic of the nature that hopefully we're not going to experience again in the near future. What we're trying to share over the next 9-10 minutes, as Gitanjali said, is looking at how the urban slums in India, particularly in Mumbai, which is in the state of Maharashtra, was the worst affected state in India with respect to both COVID number of cases as well as mortality. And we would be trying to share what we saw as the experience in community engagement, as well as the lessons that were learned that hopefully can inform action both at the policy level as well as at the practitioner level in India and beyond. Next slide, please. So we undertook this study at the height of the pandemic in India in June and July, when the cases were really raging and the curve, so to speak, was rising very rapidly in India. And the slums, particularly in Mumbai, were quite the hotspot of COVID cases then. So in April, in Mumbai, about 31% of the containment zones, which is where the number of cases were large and those zones were contained by the local government, were situated in the slum areas, or what are more commonly called as the densely populated low-income settlements or shanties or bastis in Indian jargon. By May, that 31% statistic had grown to 57% of the containment zones in Greater Mumbai due to COVID were in the slums. And by late June, that grew to as high as close to 96%. So one can imagine the spread of the pandemic in these settlements. And the reason we undertook this study was to really look at what's the nature of the COVID response, both for prevention, but also control and tackling of the pandemic. And particularly to put a spotlight on what communities are doing in tackling the pandemic. I think what's written much more about is the role of government, which of course was the command and control center during those months and now. But in the slums, the communities played a very pivotal role in containing the pandemic and ensuring some levels of behavior change. And as I mentioned, we hope that the learnings presented today in terms of the different community engagement models and their roles can really inform not just how we deal with pandemics, but also more widely looking at how these models could inform infectious disease control, as well as how health systems could become more robust and resilient in such settlements. Next slide, please. So what we found in the slum context in India is that their needs were not just large, but very multidimensional in the face of the pandemic. And again, for context, 24% of India's urban population, which totally is about 100 million people, live in slums. And in Greater Mumbai, that number is much larger, which is about 42% of Mumbai's population, about 12.5 million people live in slums. So the numbers we were talking about to tackle the pandemic were indeed large. On this circle, you would notice that the needs that the slum communities were facing were not just related to the pandemic and health, but also related to food, nutrition, wash, livelihoods, transportation, etc. And I would particularly like to talk about the livelihoods aspect, given the very stringent lockdown that India imposed, like some other countries. And overnight, a lot of the informal workers and migrant workers who were primary residents in several of these slum areas were thrown out of employment and their source of food and livelihood. So we found that in those months, not just tackling of the pandemic or a health response, but both government as well as other respondents, whether they were NGOs or philanthropies, had to deal with multiple other needs ranging from income support, providing food and water, to ensuring nutrition of the newborn and young children. And of course, as the pandemic continued, also ensuring safe transportation when some of these migrants started to go back homes to their villages where they came from. So this in many ways forms the crux of how the communities engaged in terms of the different needs that were felt. Moving on to the next slide, we looked at why it is critical to engage communities, and there were four major reasons that bubbled up. The first one, as I mentioned, was because the slum context was so unique. Some were horizontal slums with small hutments located over vast areas, and some were poorly settled, multi-storied buildings with almost no amenities of water, sanitation, waste disposal, etc. Similarly, a couple of slums like Dharavi, which are well written about, had a strong economic base in terms of people having a source of livelihood and several small and medium enterprises. But many other slums that were not registered by the government of India had absolutely no source of sustenance or livelihood within the slum settlement. So the context to give these examples were very different, and understanding the role of the communities was critical to tailor the pandemic response in each slum. We saw the diverse community needs, and each slum varied in the degree as well as the nature and intensity of these needs. So again, engaging the communities was critical to both understand the intensity of their needs and then form solutions to address them. The third big area was trust, and there was a lot of social stigma and fear attached with COVID-19 in India, I'm sure similar to many other countries globally. And initially, a lot of the communities, due to their own socio-cultural norms or just fear of stigma, were very hesitant to come forward to report symptoms or indeed go forward for tests or being contact traced. But over time, engaging communities, particularly religious and faith leaders, who the communities had deep trust in and deep social ties with, really built their muscle for adoption and compliance of both COVID prevention and the control services that were provided by government and others. And finally, of course, to scale the impact of what was being done for the pandemic relief was critical to engage communities. And here we saw several examples, right, from communities being engaged in providing their own food through setting up food kitchens, through self-help group of women workers in the communities, producing masks and PPE kit for local use, other local communities providing telemedicine, etc. So all of these helped immensely for engaging communities. Moving on then to the next slide, we saw that the main roles of these communities were to help awareness and change behaviors for COVID. The second was around providing community level screening, as well as other services like food support and other control and prevention services. And finally, a lot of them help to inform government action and response, both in terms of essential health, sanitation, and water services, but also, of course, importantly, the health centers that were accessible to them for the pandemic. At this stage, I'll hand over to my colleague Niloufar, who will talk us through some of the models in which they engaged in these activities. Over to you, Niloufar. And next slide, please.
Great. Thanks, Preeta. So here we really try to understand what the different models are for how slum residents individually and collectively are getting involved during the COVID-19 crisis. And as you can see, we observed three models. It's important to say that these models are not really discrete or watertight. They are fluid, they flow into each other. But the three different models we observed, as the name implies, are recipient models, where the community plays the role of a recipient, and it's quite a passive role, and they just receive services from external stakeholders. The second model is that of a partner, where the community is collaboratively working with the external stakeholder, which could be the NGO, or which could be the government, or any other funder, even in this case. And both of them co-create solutions. The community really provides input into any sort of intervention, and also helps in some form of implementation. And finally, the owner model, where the community, as the name implies, really owns the intervention. So where decision-making is concerned, taking a call on what exactly needs to be done, and really running the intervention quite autonomously. That's where the owner model comes in. As you can see, there is an increasing community participation, and there are a number of factors which really determine what model plays a role in which setting. So moving to the next slide, you'll see that across all these three models, we found examples of organizations that were working and providing services. In the recipient model, we have organizations like Praja and Swasth Foundation that were providing food, mental health services to the community. There were organizations like Sneha, which works in public health and reproductive health for women in slums, which was collaborating very closely with the community and providing them services. So for example, they were creating materials, and the community members were disseminating those materials, which had evidence, awareness information on COVID-19. And finally, owner models, where there were collectives within the community that were running the intervention with just like high touch support from organizations. Which really brings us to the next slide, please. Which really brings us to the important learnings from this exercise. And if there are 5 main learnings that we were able to observe. The first one is that the socioeconomic characteristics of a slum influence its community engagement. So the legal, political, and physical characteristics of a slum, as well as the social capital of its residents, really determine the community's vulnerabilities to the pandemic. So if you look at notified or very well-established slums like the Dharavi in Mumbai, these slums have strong formal and informal networks, and they're able to accommodate very high degrees of community engagement, as opposed to non-notified slums like Ambujawadi and Ambedkar Nagar, which have migrant workers and very informal networks. The second learning is that community roles often shift during shocks such as pandemic. So as understandably, a pandemic is a state of shock. And so there's a very high degree of flux in community roles and engagement models during these crises. When erstwhile strong communities may slip into becoming recipients, for example, or they might even step up to innovate and lead local response initiatives. So one community can really play multiple roles depending on what the need is and depending on how severe the shock is in their particular area. The third one is that the role of the stakeholders continuously adapt as the community needs evolve. Again, depending on factors such as slum characteristics, the specific COVID-19 response activity, and even support from external stakeholders. One organization can play multiple roles. So for example, in the M East ward in Mumbai, one of the organizations we worked with, the Tata Institute of Social Sciences, was serving all three roles. So they were providing services to the community, they were partnering with this community, and at the same time, they were also providing high-touch support to communities that were running their own interventions. Another learning is that communities, even in crisis, are very keen to script their own development. So our interviews with community volunteers and leaders were univocal that communities wish to retain and regain their autonomy, and even most importantly, their dignity and self-reliance. So they are willing to go the extra mile to really make sure that they are taking a part, they are participating in what is needed and what it really takes to achieve any sort of impact in that context. And finally, social capital, cohesiveness, and capacity building enable greater community engagement. So we found that in the owners and the partner models in slums, one really important prerequisite was a strong peer-to-peer bonds and community cohesiveness. So organizations like UVA and TIS, which were able to successfully launch partner and owner models, had really been building those networks within the slums. They had very good relationships, they had good communication channels, and they also had a lot of cohesiveness with the slum and with the members of the slum, which helped them help the slum communities eventually. So that really brings us to the end of our session. If you have any questions, please feel free to put them in the chat box and we can take them up at the end of the session.
So thank you, Niloufar and Pritha, for this presentation. So, and as Pritha mentioned, as Niloufar mentioned, sorry, we'll be taking up the questions at the end. And please feel free to put them in the chat box. And then at the end, we'll have a discussion across the presentations. Also, after all the presentations are done, there may be some useful cross learnings that we have. So now we move on to Kenya, where we have a presentation to know about and better understand SHOFCO's COVID response. SHOFCO, Shining Hope for Communities, works in urban slums in Kenya, currently impacting over 2.4 million people. And Kennedy Odede, who is the CEO and founder of SHOFCO, will be making a presentation. So over to you, Kennedy. The 10 minutes presentation, and I'll give you a reminder after 9 minutes. Thank you so much.
Thank you so much, Zubin. And I was very impressed to learn what's happening in India from Pritha and that. Yeah, so thanks so much for that. So SHOFCO is a grassroots organization that was founded in Kibera slums. And I want to just share with you the learning journey. I think COVID for us was a disruptor. We didn't really plan for it, and we're going to have a lot of learning together. So I want to share with you what we have done since really we got hit by it. So I will go next, please, on the next slide. Yes, as you have seen, the UN says that almost over 1 billion people live in the informal settlement. This is really tough. And when I talk about informal settlement, that's where I grew up. So what is that for me? That means it is inadequate sanitation, poor sanitation, and there is people are really disadvantaged in terms of social economic, so they really struggle. And why COVID has become a big issue when it comes to the slums is because of sanitation. We all know that people in this area live really congested. So when we were really affected by this, we realized that the only solution we heard from World Health Organization, Ministry of Health in Kenya, but to be told, we felt that this population has been ignored. Nobody talked about them. When I walk in these slums, I hear the word they're telling us, they say social distancing, use clean water, don't go out. And they're like, we don't live in those apartments. We share pit latrines. Who is there to speak for us? And then, as Peter talked about, I realized the role of the community. And this became part of the trust. People don't trust their government because they live in shanties, so which means they feel ignored. So it was really important for us to take initiative from the grassroots level to reach out. What can we do? And honestly, it was all about basic needs. You know what I mean? How do you provide for them clean water? And how do you provide the soaps? How do you provide the information that comes from WHO and make it really easy for them to understand on the ground? So far, we were able to reach over 1.8 million slum residents where we did door-to-door screening them. As I remember, at first they said, this COVID is for white people. You know, it's for Zungu, they call it here. It's not for us because it was really killing people from the global north. And I'm like, no, it's not like that. So the role of community organization was really important, and also religious organizations in the community. So that way we were able to reach out to them and understand what they need. And that's how we're able to do door-to-door and try to provide sanitizers, you know, setting up hand washing stations in the communities. And I really, when they believe in something, what I learned from this journey is that community don't want to be told things. They want to be part of decision-making. And then I asked them, what can we do? They came with me with an idea like, listen, can we put up hand washing stations across the main entry points? It really worked out so that they can wash their hands there. And then I also saw the power of also working with the government, you know what I mean? Because these people don't really able to get access to these areas. But through working together with them, we were able to provide over 42 million liters of water, of free water. And that was very important. And we also saw there was an increase in gender-based violence, you know, as this thing make people to be in the houses and stress and all this thing happening, women really got a lot affected. We saw the 90% of increased cases of gender-based violence. So anyway, just to summarize here quickly is that the issue was also food and at the same time, cash relief, which I really support, whereby somebody wants to say what they want to buy for food. You cannot just provide food all the time, you know. So we came with the idea of providing a cash transfer that was done with other organizations like Give Directly, also with the government of Kenya, and we were able to reach over 35,000 vulnerable families. Next. Yes, again, how did you do it? First of all, as Peter talked about before, is that these people really feel, they feel most of the time their dignity has been ripped away from them. They feel they're living in the mercy of other people. They have been forgotten. So the first thing we really learned was that community ownership is very important. What is community ownership? Community ownership is when you are able to listen and engage and understand and work with their local leaders. It can be religious leaders, can be sheikhs in the community, can be pastors, women leaders, you know what I mean? And be like, no, this is a challenge. COVID is here. How can we handle this? What are your solutions? Because honestly, for me, most of the time, I find these people living in this situation, they understand better how to solve those problems if we can only listen to them. So I learned that, and I saw the power of community initiative, whereby they're the one now going out, talking about COVID, understanding it, and the idea of partnering with the government to educate them so that they can be the role models seen going door to door in those communities. It really worked so well. Another thing I talked about was trust. Trust, what is trust? You cannot trust a stranger. You cannot trust just a word coming from the government or from the top. you know what I mean? The World Health Organization, you know, I think it's the role of organizations that are in the community to take those messages and unpack it to the community that already trust them. How you get trusted? If you've been in that community providing clean water already or providing healthcare programs, they know you, they feel connected to you. So you can help them with the information. Another thing that, another thing that we saw was the practical solutions. This is very interesting. For me, when I grew up, I realized that anybody who make things complicated, they are confused. They don't know what they're talking about. You have to make things to look practical, you know, for them to be able to get it. So, for example, door-to-door distribution of soaps, don't need much. We just have community leaders. We bring what we call community health workers, health volunteers coming together, owning the message, going door to door. It really worked a lot. And just to give you a quick overview on this, I remember when there's a research was done in Kenya here in Nairobi, which organization really was able to solve your problems. And I remember Shofco got 45% as the organization that was there for them during the COVID. And it's just, for me, it was more about giving them practical solution that they can help you come with. The most important part is that government is very important. And for the first time in my life, I've seen when the government now like, hey, Kennedy, how can we penetrate these areas? We call them last miles, I mean. And then we were able to work with the government, and we saw also them coming in with this service delivery. I was able to be appointed in with the Minister of Health to be in the task force, so I can lead the group on informal settlement. You know, what are the things we can do? You know what I mean? Because it's a unique area. It's not easy to work in those places. Next, please. Yes, let's go back again. What are the challenges we saw? What are the challenges we saw? As I said before for the beginning, social distancing is a luxury. It doesn't really work when people are striving, where people live in really congested area where they live in 10 by 10. You don't have a fridge. And that luxury of having a food in a freezer that you can eat later. So it was really tough to do that. Another thing I saw was economical fallout. Most of these people living there, honestly, for me, they are the people who are running the city. They are the engine of the city, and yet they're getting forgotten. So when this face-to-face thing called COVID came in, they lost their jobs. They were nannies, they were drivers, they were guards. So it really hit them hard. It was so tough. Even right now, they're still recovering from this. And people could tell me, like, Kennedy, I'd rather die from hunger than to die. I'd rather die from hunger than COVID. So they don't care about COVID. It's about survival to the fittest. I want food. I'm hungry. You know what I mean? So if you give me money, should I buy a mask or buy food? They'll go for food. So that's something I learned on that. So, yes. So yeah, the thing that we see also set back in developing outcomes that I discussed before. So we in this community, they don't have internet. So honestly, how will they do education? So they have been really afraid on that. Again, gender-based violence was increasing, which means women and girls suffered more during this COVID time. So right now in Kenya, we are seeing the second wave coming up. And yes, and I think that we have to be prepared because it's going to be really, really tough. Please, next. Yeah. Yes, so working with local leaders is very important as we work on good behavior. So we're able to work with community leaders, revisiting post-COVID economy, you know, trying ways to how to help these people by cash transfer, in helping their businesses, those kind of things, you know. And also important for us to do what is called the early warning system. So we're able to track this using the data, but at the same time, there is misinformation happening. So how do we handle that? I mean, so it's very important for us again to work with the Ministry of Health, you know. So when we see through our screening, we can use that quickly to inform the government of what we are seeing. Next. Yes, just to summarize again to finish is that it was a terrible disease, it's still there, the infectious disease, but at the same time, we have seen, we talk about community development, community ownership. For the first time really in history, we have seen the power of the community. And I think right now, we all agree that each communities in India, wherever they are, they really came together, and we saw the power of local organizations trying to fight this, this disease, while people were running away to their country. You are on your own. And honestly, I've been reading a lot. I've been impressed how communities were able to rise together to fight COVID. So that's when, again, the power of community is very important. Please, next. I want to say thank you so much. I know before I got stopped, but I hope you're going to have some questions. Thanks so much.
Great. Thank you so much, Kennedy. That was really useful. And I think we all learned a lot from your experiences in Kenya. So moving on now to Ghana, we'll have Dr. Matilda Abarizi Ako, who is an organizational anthropologist at the Institute of Health Research in the University of Health and Allied Sciences in Ghana. She will be presenting on the socioeconomic and health effects of COVID-19 among vulnerable populations in the Ashanti and Volta regions of Ghana. Thank you very much, Matilda.
Thank you very much, Dr. Lamba. Yeah, the title of my topic, as she's already mentioned, is socioeconomic and health effects of COVID-19 among vulnerable populations, evidence from the Ashanti and Volta regions of Ghana. Can we move on to the next slide, please? Next slide, please. As a way of background, Ghana has been making efforts to strengthen health delivery, curb widespread infections, and to mitigate the social and economic costs of the effects of COVID-19 since March 2020. Please, the reference should be myjoyonline.com 2020 and not Hansen, sorry. Some of the mitigating packages are 1 billion Ghana cedis for small and medium-sized enterprises, 3 billion Ghana cedis to support facility for local industries, and reduction in interest rates among others. However, the Ghanaian economy is largely informal. These packages are more focused on the formal sector relative to the informal sector, such as vulnerable people who live in urban slums and those who live in rural residents, who actually live from hand to mouth, or as we call it, they earn wages daily. And for that matter, they are not even visible because they are not really in any, they've not been documented. And they were already struggling with economic hardships even before the advent of COVID-19. So they've been hit very hard. Unfortunately, they are not even covered by these mitigation packages. So this study, therefore, necessitated the need for us to investigate the socioeconomic and health effects of the pandemic on these vulnerable population, that is urban slum dwellers as well as rural residents. Please, next slide. So the objectives of our studies were as follows: to examine socioeconomic and health effects of COVID-19 in rural communities in the Volta region of Ghana, and also urban slums in the Ashanti region of Ghana. And our second objective was to understand how communities are participating in COVID-19 intervention processes and how they are owning the processes. Our research questions include: how has COVID-19 affected jobs, incomes, affordability of food, access to healthcare and mental health among these populations? And how are interventions around COVID-19 influencing empowerment and transformation processes in these regions? Please, the next slide. Next slide, please. Okay, so what did we do? We used a mixed method approach that is quantitative and qualitative, and we worked in 2 regions. And as you can see, I don't know whether you can see my cursor, but we worked in, the arrows indicate the Ashanti and then the Volta regions. That's where we worked in. In the Ashanti region, we worked in an urban slum. In the Volta region, we worked in a rural community. And purposive and simple random sampling techniques were used to administer questionnaires to 400 residents, 200 in the urban slum in the Ashanti region, and then 200 in the rural area in the Volta region. We also use focused ethnographic design, that is for the qualitative aspect. We did in-depth interviews, observations, focus group, and case studies. And our study participants included healthcare officials, community leaders, a cross-section of community members. As you can see from my right, that is a training session for research assistants who collected the data. Then the picture in the middle is about a research assistant who is carrying out, administer a questionnaire to a community member using a tablet. And then to my extreme left, it's a research assistant who is carrying out participant observation. This is what we call a triple tap, which is used for hand washing. So she's participating to see whether there's actually water and whether it actually works. So please, let's move on to the next slide. Next slide, please. Okay, thank you. So what are our preliminary findings? Our preliminary findings indicate that nearly 94% of respondents agreed or strongly agreed that COVID-19 had negatively affected their jobs. Also, more than 76% of respondents stated that COVID-19 had negatively influenced their ability to afford enough food. And nearly 66% of respondents agreed that they were afraid to seek healthcare from a health facility, even when they are unwell. And close to 75% of respondents stated that COVID-19 makes them feel anxious. Can we move on to the next slide, please? Other findings are some communities feel that vulnerable populations have been neglected. For instance, an opinion leader who's a pastor in a rural community said to us, it seems that government, that is, have forgotten about those of us in the village, in the villages. There are a lot of old men and women in my church who are not doing any work. And then some respondents reported that they had to go into self-help projects because they realized that they had to support the vulnerable in their communities. However, these groups, they indicated that they didn't trust their leaders. And for instance, an opinion leader or a youth leader in a slum residence said to us, we have some youth here. They came out with an idea. We started to save 1 cedi each. And before we realized, we had plenty rice and oil, which we distributed to all the aged. Even if the government should provide support for us through the leaders, they would eat everything with their families. So these are the experiences that we had from the slum dwellers as well as the rural folks. So can we move on to the next slide, please? So what are the lessons that we learned from our research study? First, that government should provide mitigation packages such as interest-free credit facilities and subsidized food products for the vulnerable, especially those in rural and slum dwellers, because majority of respondents agree that COVID-19 has negatively affected their jobs, as well as their ability to afford enough food. As we realize, these people were already even suffering from economic hardships even before the COVID-19, and they've become worse off now and they need a lot of support. So government should find a way of reaching out to them. And then also collaboration between the Ministry of Information, the Ministry of Health, and the National Commission for Civic Education on community outreach programs should aim at sensitizing rural and slum dwellers on the need to seek healthcare for their health from health facilities, as well as to be less anxious. However, they should be sensitized to adhere to all the preventive measures in fighting COVID-19. And then government also needs to engage effectively with the various groups in communities to ensure that economic support is provided to the most vulnerable. Because we've noted that though we agree that communities are vulnerable, even within communities, there are even more vulnerable people, such as aged people who are invisible. So some of the interventions do not even reach them. So government needs to engage the various groups, as we've realized that communities don't even trust their leaders. So there's a need to engage all the groups so that no one will be left out. Then finally, the different government agencies need to encourage self-help projects, as well as work with existing community groups to initiate development projects that meet the needs of vulnerable populations. Whilst we are all crying about COVID-19, but we understand that at the end of the day, there will be a silver lining, and that is where communities who have started with certain initiatives can be supported to move beyond COVID-19 to carry out development projects through the support of governments. So at this point, I want to thank all of you for listening. I want to thank my other investigators, such as Dr. Ofusu, Dr. Imran, Dr. Dalaba, and Professor Margaret Japon, who are part of this study, as well as the research assistants, and then our study participants and WHO for this opportunity. We'll be very happy to take questions at the end of the session. Thank you very much.
Thank you, Matilda. So next we move on to a very different setting and also a different issue, which is also very important, a vulnerable group that is often not as studied as, say, slum dwellers, industrial migrant workers, where in growing economies, we see there are a large number of industrial migrant workers who are also very vulnerable to COVID due to their living conditions, often due to their daily wage status. And here we have with us from Vietnam, Dr. Bui Ha from the Hanoi School of Public Health, who will be making a presentation based on research they are doing in this area in Vietnam. So Dr. Ha, over to you.
Thank you very much. Good morning to everyone. Good afternoon here from Vietnam. So my pleasure to present briefly the study on community engagement in combating COVID-19 among migrant workers in industrial zone in Vietnam. Next slide, please. So you know that COVID-19 brings a lot of impact, severe impact to different people, but in particular it migrants. Migrants were severely hit because of the vulnerability. They are more likely to have higher risk of having COVID due to low-paid job and unstable job. And because of the unstable job like driver or factory worker or street seller, they are more likely to have higher risk of losing job and income due to government regulation on COVID-19 prevention. So the government applies a strictly nationwide lockdown and social distancing during the COVID-19 pandemic. And since they have low-paid job, they often live in unsafe living conditions. It's very crowded and lack of access to clean water and other basic conditions. And also as a poor and low-paid job, so they often have a higher risk of lack of access to healthcare related to COVID-19. Next slide, please. Next slide, please. Hello. Yeah, so we carry out study to address the problem. We have three objectives. The first is to explore the factors that affect migrant workers in Vietnam. We try to address in 4 levels: at individual level, community, occupational, and environment level. And the second is we try to identify the role of community engagement in tackling the impact of COVID-19 for migrant workers. And the last one is to propose intervention around community engagement to mitigate the impact of COVID-19 on migrant workers. So next slide, please. Now we use a cross-sectional design study. We're using holistic cumulative risk assessment framework. The study was started in August 15, and we complete data collection and complete data analysis. We are now on the process of report writing. The study was collected in 2 provinces, in 2 industrial zones, with more than 400 migrants. And we carry out with 36 key informants in those 2 provinces. We use a data for the data analysis for quantitative survey and thematic analysis for qualitative survey. You can see here the picture of 2 industrial zones, one in province in Ninh Bình and the other one in Bắc Ninh province. There are 2 very big industrial zones in Vietnam. So please, next slide, please. So very briefly about very first finding from research study, we found that there are 7 factors that affect migrant workers during pandemic. Overall, the migrants from the two industrial zones have quite good living conditions in the dormitory. Almost all of them have access to clean water, toilet, and internet services. In Vietnam, now internet access is very popular in Vietnam. But due to COVID-19, about 8% have losing the job from permanent into into casual job, and about 4.5% loss in job, but overall the salary reduced. The knowledge of those people overall is good. They have a good knowledge on symptoms, on transmission way, and prevention methods. They all want to comply with preventive measures that they wearing masks, face mask, frequently washing hands when entering the public space. The company in the industrial zone also want to comply with the preventive measures. They also provide support to migrants, including personal protective equipment, face mask, or also provide subsidy for the cost of renting house up to 6 months, depending on the factory. The landlord of the dormitory also comply with preventive measures and also provide some support for the tenants. They can reduce some cost of renting or cost of electricity or water. However, from the study, we found that the government provided public support for migrants who have suffer from COVID-19, like losing the job, losing the income. They can apply for the subsidy from the government, but there was very complicated procedure for getting the government support, and actually none of the migrants can get the support. So next slide, please. Interestingly, in Vietnam, we found community empowerment is very effective in COVID-19 preventions. In Vietnam, since pandemic in January, the Vietnam government have set up the committee on COVID-19 prevention, and that consists of multi-sector stakeholder. The similar structure was set up in all levels at national, province, district, and commune level. At the commune level, they are the committee responsible for all activity, including testing, isolation, or quarantine. They can mobilize the different sources, including finance, human and material. And health sector is responsible for all technical activity like testing, identification for isolation or quarantine, and curative care. We found that there is very interesting mechanism in the community that is called community supervisions. This mechanism does mean all the community, the local community member have to identify themselves, the high-risk cases, and then notify to the committee member. And then committee member will follow, identify the people who can send for the isolation or quarantine or hospitalizations. In the dormitory of the migrants, the landlord had to identify those coming from outbreak area. In the last, in this year, when we passed two waves of the pandemic, so the community supervision is so effective. All people coming from outbreak area were identified by the local community, and this had to stop the spread of the disease within the community. They contain the epidemic, the cases within the local community and cannot spread outside the community. So we found that it's extremely useful and effective for these cases. And the government putting so much effort on providing information on COVID through different channels. They use it TV, radio, they use it also Facebook, Zalo, Messenger. They send it 2 times per day to telephone, to everyone telephone. In the morning, in the afternoon, they update information on the new cases, on the dead cases, and then also the remind the preventive measure. So it's very extremely important with the informations. They also designed different apps and COVID or Blue Zone help the people to report and record the personal information. And if they have the contact with the high-risk cases and they record in the blue zone, then they will automatically detect the high-risk cases. So we found it extremely also very important to have to identify and isolation of the high-risk cases. However, in this period, we also see that the testing, the delay of the testing result, so we can delay the process of the isolation or quarantine because there are lack of mechanism for purchasing testing material in the lab in the health sector. Next slide, please. Next slide, please. So from the study, we found that since we have very effective governance structure of COVID-19 prevention, so we recommend, we propose that the government can continue to maintain the governance structure with the committee, the community, and then continue the committee supervision mechanism and revise procedure to identify the beneficiary, to get government support and revise mechanism for purchasing testing material for the health sector. Next slide, please. Next slide, please. So we would like to share some lesson to other people that community engagement is very effective to local committee, the multi-sector stakeholder and responsible for own activity, and community supervision is effective. And we can use different mailing channels to provide update, reliable information, and apply different apps to report and record personal information related to COVID-19. So I think that my presentation is the end here. So I'm looking for comment and question, and I'm very happy for this. Thank you very much. So it's some picture.
Thank you very much, Prof. Ha. It was lovely to hear from you and lovely to hear your lessons from Vietnam. So now we're moving on to Sierra Leone, where we will hear from Francis Reffel, who is founder and director of the Centre of Dialogue on Human Settlement and Poverty Alleviation, or CODISAPA, and he has also pioneered the establishment of the Federation of Urban and Rural Poor, or FEDRIP, and he will talk about COVID-19 in informal settlements in Freetown. Over to you, Francis. Thank you.
Hi, everyone. It's a pleasure to be part of this session, and I want to thank the organizers for inviting me to be part of it. Excuse me, just giving a quick context, can we just move on to the next slide, please? All right, while waiting, okay, thank you. Of course, already they've spoken about what CODISAPA is, established in 2011, but let me just give you a quick context of the space that we operate in. Sierra Leone, of course, is a population of 7 million, and Freetown, where majority of our work is focused, has a population of 1 million some hundred. And out of that 1 million, it is estimated that 35% of that population lives in slums and informal settlements. So we are talking about 350,000 residents living in informal settings. And so because of that kind of space, so our work over time since 2011, we have been able to mobilize slum dwellers, that has been established as a Federation of Urban and Rural Poor. So this kind of alliance actually has helped to create a synergy of professional and community knowledge. And we are part of the SDI, which is a Slum Dwellers International Global Network, which is actually focused on mobilizing slum dwellers as well as informal settlers to create a voice, and a space for them to engage at national, regional, as well as at global level. So basically our mission is to seek to promote, economic and environmental empowerment. Next slide, please. Yeah, so coming to the issue of COVID in informal settlements, of course, they are hearing from colleagues from other contexts. It's just dawned on me that the situation of slums, informal settlements, poor population, we are grappling with a very similar situation across the globe, and principally among that is the loss of livelihood. So basically, my talk is really going to focus a little bit on well-being, not necessarily specifically on health issues, but a general well-being situation. So in this context here, I try to look at three major challenges actually that COVID brought into informal settlement. One was a lack of context-specific messaging around COVID-19 for informal settlements. Of course, I had from Kenya, my colleague from Kenya, talking about, when governments, of course, global institutions and our government also adapted that there has to be social, physical distancing. The slum dwellers, like, how is this possible, with overcrowded, shelters, no space for us to. So that was really an issue for them to be able to live with, to accept and really to live with. They saw it quite impracticable within their context. The other challenge is that absence of information flow between informal settlement residents as well as governance actors. Of course, mostly when government is planning for situations like this, their focus really are on formal settings, and there is always a tendency for them to just disregard the informal settlement because they are regarded as people that are living in illegality, and so their plans are not really reach. So really also in terms of information flow, of course, the first point that talks about no context specific messaging clearly spoke that in fact when government was designing messages to address those issues, they did not take that into consideration. Another challenge was limited support for most vulnerable. Of course, it boils down to the same issue that since government was planning for formal settlements, disregard for informal settlements, resulted into very limited support for most vulnerable populations. Because as government was planning, they did not really have in mind that these people also are part of the citizenry of the country. Next slide, please. Yeah, so given those challenges, so some of the things that we did actually, is that good is in that, of course, we already have established over time a very strong social movement, social network within the informal settlements. So one of the things that we did was that we actually worked with, and of course, interestingly also, just for listeners to understand that, one key advantage that we had here is that over time we have been able to foster very strong relationship between the slum dwellers as well as the municipal council, which is the Freetown City Council. It's part of the SDI model. Instead of actually just challenging issues, we believe in the process of building partnership, relationship, with respective authorities. And of course, within this context, our entry has been building very strong relationship with the Freetown City Council. And so we work with them, to be able to develop some messages that is applicable to the situation of informal settlements. So in addition to that also, because of our situation, the reality of, the temptation to really keep distance. So we became innovative by developing a case monitoring app, because we are caught up in between, continue our support to informal settlements, but at the same time ensuring our safety. You know, once the COVID landed in our country, you know, one of the things that we did was we engaged with leaders of the slum dwellers as well as the professional office, and we developed our own approach to responding. So it was very clear between us that we cannot be coming to the community regularly because of the, you know, the requirement to actually keep distance and to ensure safety of individuals. So we developed the case monitoring app so that that was used by the slum dwellers within the settlements to be able to report on COVID cases, but at the same time to also report on social, you know, challenges. Sorry. Can you start the screen? I think there was a short interruption there. Can you hear me? All right, great. So I was saying that we use that app to be able really to give the opportunity for slum dwellers to be able to report back on those incidences, which we are able to put together and share with respective authorities. And at the same time, we worked with the council to actually enhance their support. I mean, because of the existing relationship between us, we are able to, you know, influence the council to prioritize majority of its intervention focusing on slum dwellers. So in fact, through that engagement and, you know, interaction, the council was able to attract a lot of funding even from the EU and other actors, which we are specifically designed to target informal settlements. Next slide, please. Hello. Okay, thanks. All right, so the other thing that how we did all of this, you know, we did it within the framework of one, as I said, we capitalized on the existing community structures to drive the process. You know, COVID, of course, has taught us that, you know, everybody has to take up his or her own responsibility. So one of the driving force, you know, to our work is ensuring that those existing structures are the ones that will lead in most of their activities within their settings. So we have established within the Federation community-based disaster management committees. So those are the drivers that we actually capitalize on, that we are doing case monitoring related with local authorities, in-situ local authorities, to be able to, you know, to drive community agenda. As I mentioned, also we leverage our partnership with the FCC, the Freetown City Council, you know, to actually demonstrate a kind of precedent-setting collaboration. That relationship actually also had to filter up to, you know, the regional as well as the national government to see the need of, you know, actually redirecting their plans and their support for informal settlements. As I said, also we capitalize on our tech skills that we have, you know, the tech set skill that we have to be able to develop, you know, to drive our data-driven advocacy methodology. Of course, as I mentioned before, is that our approach in actually engaging is to provide answers to some of the questions, you know, as we engage with the respective authorities. Like the slum dwellers have you know, a slogan that says, we are the problem and we are the solution. And so the way that we find a solution to answering, you know, some of the problems or solving some of the problems is to actually use our data that we collect on a regular basis that reflects situations of slums, and that we use actually in our advocacy work. Also, we had to leverage partnership with other non-state state actors, like, we have the Arise Hub, which is health accountability research. So we partnered with College of Medicine and Allied Health Sciences. We partnered with the Sierra Leone Urban Research Center, in which, our partnership was able actually to amplify the voices on informal settlements. Wow. So, sorry, my time is up. All right, quickly. So as we were doing all of this, some of the challenge that we have was that, there are so much growing expectations, from the communities. And so we had limited resources, also the long-standing centralized, approach of central government actually also limited the local government to respond adequately. And also the restricted issuance of passes during lockdowns and curfews actually was a very extreme situation for us to coordinate our work. Next slide, please. All right, so how we did that, of course, which all capitalizing on our past, and we're able to foster, relationship across the board, state as well as non-state actors. We ensure that jointly we're able to challenge central government to ensure that they decentralize, COVID-19 response plan, which resulted into district response teams, that, for example, at the end has to respond to the Freetown municipality. Of course, also, we use our digital platform to be able to coordinate those actions. Next slide, please. It's becoming pretty slow. All right, so some of the lessons learned is that we realized that, community was able really to self-mobilize their actions, to be able to, and became more creative. When the issue of even like mask and, other stuff came up and there was this misinformation, those local communities on themselves were even, fabricating their own mask. So the other thing is that there is actually a great need for community actors to be the center of their development aspirations. I mean, COVID has also the issue of working in isolation. So if you don't have the capacity, you will just perish. There is a growing importance of the use of digital tools, and also the importance of community structures and readiness. In our case, as I mentioned, because we have existing local structure, we only can leverage those kind of resources. And of course, there's a need for government really to improve their national health systems, because of COVID, isolating nations. Next slide, please.
Francis, sorry to interject, we're really out of time.
Okay. All right.
We just finish this now so that we can go on to the next.
Yeah, please. So one of the things that we learned is that there is always that kind of, we realize when assessing the uncertainty, the situation of uncertainty, government use that actually to enforce evictions, and there's a lot of increased mistrust, in state institutions. Yes, I think the last one. All right, I know people will be asking questions, but let me leave this question to the platform. What is the future for global partnership and collaboration? And secondly, has the emerging digital and virtual platforms plagued by misinformation emboldened advocates of isolationism? Thank you very much for listening.
Thank you very much, Francis, for that very interesting presentation. Next, we have a presentation on Tostan's Community Engagement Program, which functions across multiple countries in West Africa. And over to Yusuf Sani, who will be presenting from Guinea-Bissau. Yusuf, over to you.
Hello, everyone. Good day. Good morning. My name is Yusuf Sane, the National Coordinator of Tostan Guinea-Bissau. Tostan is an Africa-based community development organization that empowers communities to develop and realize their vision of the future, and we inspire large-scale movements leading to dignity for all. And our partner communities are mostly rural, resource-poor communities with great potential. The Community Empowerment Program is Tostan's 3-year holistic and human rights-based education program that empowers communities to lead their own development and demonstrates consistent results in governance, education, health, environment, and economic empowerment. The CEP, as we call it for short, leads to community-wide behavior change in many areas, including social norms, and especially social norms that promote women and girls' health and economic empowerment. So it's this capacity for social norms change through the program is what made our partner communities especially adaptive when the COVID situation started. Next slide, please. We are currently based in 5 countries in West Africa, namely Senegal, the Gambia, Guinea-Bissau, Guinea-Conakry, and Mali. And through our Tostan Training Center, we train other organizations around the world on our model for holistic and integrated community-led development. And so from 2017, most of what we did really was before the COVID period with our partner communities. From 2017 to early 2020, we partnered with 150 communities in 4 West African countries. And this was our second pilot of sub-regional scaling of our program. And in the 3-year partnership with the 150 partner communities, the COVID situation started. And we started to see just how effective the community empowerment program was as a foundation for development, for enhancing their capacity, our partner communities' capacity to mobilize for collective action and for their long-term resilience in the post-program period. Next slide, please. So there are 2 components of the program that made the communities responsive, especially effective. The first is the participatory classes. We start with a module that we call the COBI. And the goal of the COBI is to promote positive traditions while encouraging discussion of how new ideas and practices can be used to help build a healthier community. The COBI also includes sessions on democracy, human rights and responsibilities, problem solving, health, and hygiene. In the second phase of the CEP, of the classes, is called the AUDE. And here the participants develop new practical skills that directly contribute to their improved living conditions. And the AUDE is composed of modules on literacy skills, mostly in the local language, in the partner community's own language, numeracy, and also project management. Next slide, please. Also, a central element in Tostan's community empowerment program are the community management committees. And the role of the community management committees is to spearhead the vision of the community. They're made up of 17 democratically elected members, at least 9 of which are women. And the CMCs, through a process of what we call organized diffusion, they ensure that information is shared from each participant in the classes to other members of the community, and that the partner community itself also reaches out to other communities and their social networks to share this new knowledge and information that's learned in the classes. And the CMCs also manage the community development funds, which are provided by Tostan during the program, and they decide who to provide microloans to and which economic activities should be financed around the community. And as we saw with many CMCs in the COVID-19 situation, these funds were a social and economic safety net. Next slide, please. In the program, what are the challenges that we faced? In the program, facilitators normally live with the communities for the duration of the 3 years to facilitate the sessions of the classes and to guide the community towards their vision. And when COVID-19 started, to ensure the well-being of our facilitators and our partner communities, we asked them to return home and support the communities from a distance. And this was really a classroom space that was quite new to us. Also, organized diffusion, which as I said, goes from information travels from participants of the classes to other members of the community, and from the community to other communities and their social networks. Now, this was very difficult to do. It was quite a major challenge because organized diffusion is really based on people coming together and reaching out to expand access to knowledge and information. And of course, with COVID, this is not what was initially or is encouraged. And also in West Africa, most of the countries closed their borders between each other and also within. And so this made access to food and financial services nearly impossible for some periods for many communities. Also, the lack of access to this movement, there were major concerns that traditional gender roles, which marginalized women and girls, had been strengthened in the communities where we were not present. And so there was the possibility that this could spill over to our partner communities, especially in a time of refocused social mobilization activities. Next slide, please. So about overcoming the challenges. In the COBE, the first module of the program, participants learned about their human rights and responsibilities, and they mobilized towards collective action to promote the human right to health, for example. In the AUDE, participants learned to read and write in their local language. So this became very useful when the COVID situation started. And with COVID, participants used Tostan provided booklets in their local languages on COVID prevention and mitigation. And these booklets were also culturally adapted to the realities of rural communities where we work, who often live in close proximity to each other. They value sharing and they prioritize solidarity. And this usually contributes to norms which perhaps may propagate the virus in certain environments. However, them having access to this content in the local language made them potential sharers, greater sharers of this information. Program facilitators, as I said earlier, also live with the communities for the duration of the program. And with COVID, we asked them to go home. And yet we also retain them as local ambassadors so that they can continue to raise awareness in their own communities and also manage radio broadcast and support with the distribution of the Tostan booklets on COVID-19 prevention and mitigation. Organized diffusion in the program, as I said, it followed a cycle of information sharing from the facilitator to class participants. From class participants to the community, and from community to community. After COVID, of course, this had to be changed, and yet regular contacts were also maintained with the communities through regular phone calls, through WhatsApp conversations, to be able to gather information and address specific needs of the communities. Also, we use radio programs to broadcast and reinforce key messages and be able to sensitize communities that were not reached by the booklets. Next slide, please. So we learned many lessons throughout this period. We'll stick to 3 for the sake of time here. One thing we learned was that knowledge on human rights and responsibilities strengthened the role of women as decision makers and agents for their community's well-being, which traditionally women were held in the background of decision making and of collective action in the community. We also learned that communities better define their priorities for well-being if they're informed on the roles and responsibilities of engaged citizens. So their sense of responsibility grows once they're aware of this information. And thirdly is that content in local languages and culturally relevant content promotes deep social norm change. And what we saw in countries such as my own country, Guinea-Bissau, most of the brochures and booklets that were provided for communities, rural communities, where perhaps we would say a great part of the population is not literate or does not speak the official language, which is Portuguese. And so we saw what's the value of this content that people cannot read and they cannot interact with, and it really does not represent their environment. So what Tostan did with the booklets was provide content in the language that people can understand and use it to share with other people in their environment. Next slide, please. So we'll stick to three lessons that perhaps we can share with people for other settings. There are three women coordinators who taught us some important lessons throughout this period, and we think it will be useful for other settings. We have the coordinator, Binta Sise from Irabato, who said once people are aware and they understand their human rights and their responsibilities, such as the human right to health, for example, they would naturally want to lead or join in on initiatives to promote these rights in the midst of a health crisis. And the second is Maimuna Sedi from Mafanko. And she said the emphasis on social distancing is clear and it's important. However, in some environments, access to information may not come through the internet, may not come through television, telephones, and radio. So some people may still have to go out and inform before we can actually start applying social distancing measures in some environments. And finally, Binta Sedi said open dialogue about the effects of gender roles during the program enabled women to gain more space for influence during the COVID period. And they were the leaders of the COVID-19 response in their communities. And this, women in leading any response really was traditionally unheard of prior to the program. Next slide, please. So we have some key questions that we're asking as we're moving forward with our partner communities and with living with COVID. We saw Tostan class participants respond to the limited access to salt and access to food. And some CMCs, community management committees, launched new enterprises as a response to this limited access. So we're wondering how communities will, in the next few months and years, tap into new markets to address the situation of food insecurity and their own economic resilience as the COVID-19 situation continues. Secondly, is that an entire generation of children, especially girls in Tostan's partner communities, have now witnessed that in one of the major health crises of their lives, women rose to the challenge. So we're really asking the question now, what will be the influence on the younger generation's capacity to aspire after they observe the increased role of women in these times of uncertainty? Thank you all so much for listening, and I would be very happy to receive questions.
Thank you, Yusuf. And we now have a few minutes for question and answer. Since we initially envisaged 15 to 20 minutes, we'll extend the webinar till 11:40 at least. That's another 14 minutes just now for questions. So what I'll do is I've received questions in the chat box. I'll read out questions for the individual panelists and ask a particular panelist to answer if I think there's something that all panelists can contribute to equally, or there's something for each one to say. I'll mention that clearly. And I would also ensure that we have representation in terms of questions for different settings, because we don't want all the questions only about one particular presentation. So if I go in order, that's something that may happen. So I'll start with some of the questions. So first, there was a question which I think many of you may be having. So will this session be recorded and recording be shared? Yes. The session is being recorded and we will share it after. Then coming to the questions to individual teams, there's a question for Francis, which says, ask more about the methods being used by the ARISE consortium. So Francis, if you could address that question from your experience in Sierra Leone.
Okay, thank you. ARISE is a global hub actually with partners in Sierra Leone, Kenya, India, and Bangladesh. And so within the Sierra Leone context, we had 3 partners, Kudusapa, SLOG, and College of Medicine. So our approach really to research is using a lot of qualitative approach, social mapping, using Venn diagram, and KIIs, phone interviews, so basically those are the approaches that we are using. Because of time, I cannot elaborate so much on that, but those are like the key ones that we're, as well as governance mapping. Yeah, so those are the key tools that we are using currently.
Thank you. So the next question I have is for Yusuf, and this deals with the question which we often get in community empowerment about, and so it's about equitable representation is always a challenge within committees. How did you ensure the most vulnerable were taken into account and listened to? Yusuf?
Yeah, I think I would say is that through the program, the classroom space really promotes participation, and that's really one key element, is that in the classes, participants are encouraged to share their ideas, share their views, and share needs that perhaps other members of the community may also have. And the community management committees also organize meetings regularly with the community members to be able to capture these views, these ideas, and these needs. And with the COVID situation, this became, their capacity to do that reduced. So we had coordinators of community management committees that went door to door. We had commissions that went door to door at a reduced pace, of course, to be able to capture this information. So the community management committees were no longer organizing meetings in mass, because that also wasn't allowed legally at the time. However, they still applied that door-to-door function to be able to interact and engage with the different needs of the community.
Thanks very much. So the next question is for Preetha and Nilofer. We've been asked, could you give a concrete example of how organizations built social capital and cohesion in the urban slums in India? What were the challenges, and how could this be taken up by local governments to increase their sustainability?
Sure. Thanks, Zubin. I'm happy to go first, and Nilofer, feel free to add. So we saw this consistently across all the organizations working in the slums, that they had invested not just during the time of the pandemic, but most often for years, if not decades, in building deep relationships with communities. So whether it was an NGO like the Tata Institute of Social Sciences, or Sneha, or Apnale, many of them had formed community-based organizations, and they called it by different names like civic action groups or other community-based self-help groups. And these organizations invested over time in both technical training as well as some of the soft skill training for these communities. The other distinctive characteristic was that a lot of these NGOs were not quote unquote external to the communities. They very much were embedded in the social networks in the communities, so built deep trust, worked with community-based organizers that were part of the project team. And similar to what Kennedy said, these kind of convener forums also help making decisions along with the voice of community. So rather than those being imposed from the outside. One particular example is the M East ward, which is a slum area in Mumbai, which has a human development indicator, believe it or not, of just 0.05, and life expectancy in today's time and age of just 39 years. And there was a sterling by the Tata Institute of Social Sciences, which deeply worked with community-based organizations there in M East ward during the time of the pandemic, both to help them get rights such as basic access to water, sanitation, and of course, a range of health response to COVID. And this was largely because, as I explained, they had built these networks over time in the M East ward, despite some of the deprivations that the slum communities face.
Nothing to add to that. I think Preeta covered it.
So thank you. I had some other questions. One was for Dr. Ha and Matilda, in terms of what you think are the research priorities in this area of engaging health systems research priorities in terms of engaging vulnerable populations. Dr. Ha, would you like to go first?
Zubin, can you repeat the question again, please? I don't get it.
The question is, what do you think are the health systems research priorities within this area of engaging vulnerable populations? What are the areas where health systems research, what are the important priority research questions for you?
I think the health policy and system research has a place in the community engagement, because you know that for the COVID-19 preventions, community is very important. But in terms of the involvement, community involvement, there is health sector plays significant role in a technical role. So if you know that how we can address how the health system can involve with the community to make the process is better. So it's very important. So I think the health policy system is important for the community engagement, because the community include also health sector there. Yeah.
Thank you. Matilda, I had a question about your slide mentioned intersectoral collaboration, and what do you, across the different sectors within government, what do you think are some of the challenges for that based on your work in Ghana?
Yeah, the challenges for that is the fact that every group tries to work in a form of a silo instead of coming together to work. And then what they need to understand is that they have a common goal. The common goal is to ensure that there is we improve health for all. So the challenge is how to bring them collaborate. One, an issue of documentation is a big problem, because they work in silos and everybody works in his own way. They end up sometimes duplicating efforts. And this affects trust relations within the community level, because they come with different stories, but aiming at the same goal. So these are the issues we need to look at: the issue of collaboration, the issue of ensuring trust relations, and issue of documentation. These are the areas that we need to look at. Thank you.
Thank you. So Kennedy, I had a question for you. You mentioned addressing increased gender violence, and this is a problem which is seen all over the world with the confinement and lockdowns, as well as the economic effects of COVID. So what exactly were the engagements and what the interventions that SHOFCO did around this area in terms of addressing gender violence issues, and also around rumor and disinformation? It'd be interesting to know what you did particularly around these two areas.
Thank you so much. So what we are doing in the community, we are working with groups, women groups, youth groups in the community. And what we did, we also have a number you can call, and somebody is on call for that night, so during the day and the night. Another thing we do, we also have what's called speakers box that are put in the communities, that when you have issue, you can go be anonymous, And the best thing I've seen really helping us a lot has been having safe houses. You see, because when there's issue in the violence in the house, most of the time you have to take the person away as you follow with the police cases. So I've seen a really good, strong connection between safe houses and community networks that we're having there. Thank you.
Thanks very much. Any other questions in terms of questions from the participants of the webinar? In terms of questions, really, we'd appreciate if the questions were actually directed to someone, and in terms of a point which can be addressed relatively quickly in terms of giving either an opinion or a factual question. So if there are any such questions, could you please type them in the chat box? Then we can pass them to the respective person who you would like to answer them. Another thing for Francis, I have a question. You mentioned the role of the apps and using public health data. And what are some of the challenges you felt in using mobile apps in these settings, and what would you recommend in terms of overcoming them?
Of course, it is clear that the use of smartphones has become quite common. But then the quality of it is quite a challenge. We realize that in the use of some of these tools, which of course bears the apps itself, is that most of them are not, are not of that quality to be able to keep, for example, the energy to keep it running. And of course, within our context, there is actually a challenge of electricity. So sometimes, while they are using it, they have to lose power. And if it happens that there is no light at that time, so it could be difficult for them to recharge and keep running the system. So that is one thing. Secondly is the skill set, of course. For these guys to really engage and really relate with some of these applications, they need more kind of intense training, because these are like new technology that is stepping in, and so the issue of very strong skill to be able to manage this thing is another thing. Of course, that could only be addressed by really building their skills in those areas. So I think those are like the key outstanding challenges here.
So thank you. There's one question further for Preetha and Nilofer, where a participant has asked how the partner organizations like UVA and TIS have addressed certain evolving needs of the community that are not their core areas of work. So I think this is going understanding how organizations have adapted in terms of engaging communities, and what are the kinds of ways they've been able to do that.
Sure. So I think there are two parts to the question. There are two parts to the answer. The first is that communities, the kind of needs that communities really faced, a lot of them were in the wheelhouse of the organizations, because they have been doing interventions such as these, which are more place-based and not really very sectorally focused. So organizations like Sneha, etc., really understand what the ecosystem is in slums and how to really deal with that. So they were equipped in that sense. Also, the interventions that were offered were not extremely technical or specialized. These were interventions to do with basic needs, mobilizing communities, etc. And so they could use the core toolkit to execute on those interventions. And the other part is that in the owners and the partner models, where the community was really doing the chunk of the work, organizations were just really helping in mobilizing and channelizing resources, which wasn't like a which also didn't come from a place of sectoral and technical expertise, but more around facilitation skills of like making sure they were able to connect with the right stakeholders within the local governments, the right stakeholders within the public health system, etc. So from that perspective, they work together very collaboratively. They were able to like leverage strengths of the ecosystem players, whether it was the government, whether it was the other civil service organizations, and even the community and the private like healthcare systems within the community as well. Preetha, if you wanted to add to that.
I think the only to just reiterate is India saw a massive rise in both likely and less likely collaborations, as Nilofer was alluding at the end. So particularly in the slum COVID response, we saw very high degrees of partnerships with philanthropists, government, local, central, state, as well as the NGOs working there. And many of those have never probably worked in the state of Maharashtra, let alone in the slums. So I would say that was one big pathway to pick up capabilities and funding where they didn't exist in the past. And for a few specialized areas such as mental health support or telemedicine, some of the NGOs very admirably ramped up capacity and capability within a span of a month or two. So again, TIS has an arm for providing mental health support. There's an NGO called Project Mumbai that our report talks about that also supported in this area. So there were a few cases of picking up specialized support in very quick time, but many others were through striking collaborations that helped address needs that they didn't previously.
So thanks very much, Preetha. And we're completely out of time. We've gone 12 minutes over, but recognizing the interest in asking the questions and the fact the presentations took a little longer. So thank you very much to all the panelists for these extremely rich and interesting presentations, and to the participants in the webinar for taking time out of their schedules to be with us, ask these questions. Hopefully there has been much learning. We've certainly learned at the Alliance from these different experiences, and we thank you once again for your participation. Thank you very much and have a great day. Bye-bye.